to discuss about heart diseases, and we are going to say what kind of modalities which can be possibly be used when we are thinking about how to screen patients of heart diseases. First, we have ultrasound, obviously, and with 2D echo. So we will know how much ejection fraction is there, how much better heart is working, whether there is a cardiomyopathy going on. So something like that. Another area we have is CT angiography for coronary arteries. Now here things get interesting because when we have CT coronary angiography, you can see the blockage anatomically, how much percentage of block is there, whether or not that patient should go for stenting or not. All those things you can evaluate on CT angiography. However, it will not tell you FFR, functional flow reserve, of the individual artery, because it will be how much flow going distally, and that doesn't depend only on anatomical aspect of it. So how do we calculate functional flow reserve? Mostly it's done with invasive methods in cath lab. CT scan as well, you can find functional flow reserve by using fluid dynamic, and there are now different softwares available which can give you functional flow reserve, or sometimes you yourself can use. Nowadays computers are that advanced that you can run those algorithms and get you those answers. Now we come to MR imaging. Now MR imaging is tricky because it's really bad at coronaries. Now the research is going on, but still it's really bad when it comes to exact anatomical blockage of it. But it's really good for function. It's really gold standard for function. You can actually plot around the ventricle and see how much of ejection fraction is there. You can see how much of area of muscle is exactly not moving. Now you can do 2D echo as well to see dynamic segments and all, but MR will give you more robust confidence in knowing that what area is exactly going bonkers there, is not moving. Now whether that area is hibernating, like for example just lazy, or that area is infarcted, that's a really $1 million question. Because if it's really hibernating, then in future and with the therapy it can work in future, obviously. But if it is dead, then it's not going to work. So how do we know that? So using MR, especially post contrast, you can see if there is an infarcted area, it will take on the contrast and it will not show a washout on, especially on delayed imaging, because that's what the dead cells will accumulate the gadolinium. So you will have that segment which is showing delayed enhancement. So I'm just giving you kind of an overview. It's more complicated than that, but more or less that's what role of MRI is, like functionally telling you how much work heart is doing, whether any segment which is not moving, whether it is dead or hibernating. Sometimes you get stunned myocardium as well. So stunned myocardium is just like either there is a reperfusion injury, something like that. So how do you differentiate between stunned myocardium and hibernating myocardium? Again, in stunned myocardium, it's just not moving, but perfusion is normal. In hibernating, because it is lazy for such a long time, perfusion may also be abnormal sometimes, but it will not have a dead tissue. So it's really difficult to tell you like exact things. Maybe I will get a more detailed lecture on that in future. Now we come to another modality, which is SPECT and PET. It is a nuclear imaging. So what we basically have is we have different radio tracers. They go and it can work two ways: either a dynamic way where it will go and work as a perfusion, or it can work as a static, like for example only dead myocardium will take take a tracer, or only a living myocardium will take a tracer, something like that. So you can have either as a as a dynamic one, or or you can have a static one. So more or less that's what we have, modalities to look at the heart. Now one modality which I did not talk about is radiograph, which is more commonly used for a number of things, which when you go to GP and you or your physician, most likely they write you a radiograph whenever you have some kind of complaint. So what the radiograph will tell you is overview things. For example, whether there is a cardiomegaly, whether yeah, and if some part of it, if one aspect of a heart is particularly larger, for example in mitral stenosis, left atrium will be enlarged, so that you can see as a double heart shadow and other things. So in that aspects, cardiograph would be like a first modality, and it should really be looked at, especially cardiothoracic ratios and all, like how big is the heart and other things. Now but all said and done, radiograph is not really a great modality when it comes to assessing function of heart, assessing anatomical aspects of heart, etc. So, radiologically speaking, if you want to know whether some artery is blocked and what anatomical region it is blocked, you will go for CT angiography. And if you need to know functional flow reserve, either you can do fluid dynamic in CT angiography, or you can go in how we have conventionally have gone with uh, catheter angiography and doing treatment at the same time if the cardiologist will want to. Then if you are looking for function, you have either 2D echo or you have MRI. And if you ask me, MRI is like a gold standard. But if you're just doing it for a screening and knowing what's really going on here and whether I need MRI or not, then 2D echo also makes sense. Where else 2D echo makes sense is congenital heart diseases and in pediatric population, where you will need to sedate child, you will need to give anesthesia to child to able to for them to undergo MRI. And that's really not something which you want. The papers are coming up nowadays for the effect of anesthesia, and it's not really clear what's really going on and what not. So in that aspect, you will need 2D echo to be done first, and then either CT angio or MRI, depending on what you are really looking at, whether you're looking at a function or you're looking at anatomical aspect. Now cardiac MRI sometimes has a niche role when it comes to pediatric congenital heart diseases. It is like through phase imaging and flow imaging, where you will able to calculate exact flow and pressure if you know the two segments flow through the two segments of artery. So that hypothetically that is useful, and it might obviate need of pressure monitoring uh, invasively, but still we don't have that much paper yet, and 4D flow and those modalities are coming up just nowadays and still pretty much in a research work. Um, so there you have it. Overall, radiological spectrum of heart and how you can look at it. Now, as I'm discussing that, I also want to just touch on some niche topics. For example, iron overload. So you have patients who have thalassemia and who need frequent transfusions. So in those patients, you have a risk of iron overload, and in them, T2 star imaging and using MRI and to see the iron overload in the heart, in liver, in a visceral organs like pancreas would be very very useful. And in those children's and in adults, one of the more things which physician and fear about is having something like cardiomyopathy and cardiac failures due to iron overload. So those can be monitored um, using T2 star imaging and to see how much of iron overload is there. Then you have other niche role for MR is like cardiomyopathies, and nowadays the research is coming in for having a genetic mutations for cardiomyopathies and testing for that, and depending on how the enhancement patterns are and where exactly there is a dilatation, you can more or less see that what thing is actually going wrong there. So so there you have it, overall spectrum of radiology in heart diseases, which is quite vast and handled by two different specialists actually. Cardiologist will handle 2D echo and um, invasive procedures, whereas a radiologist will handle radiographs and CT angiography and cardiac MR. And there is a lot of overlap between two specialities, and and a good communication is really a key when you are dealing with a patient, to able to talk with cardiologist and understanding what they want. And also from the cardiologist point of view, it's also important to convey radiologist what exactly you're looking from that procedure, from that modality, and what answers you want from radiologist. And for from the radiologist perspective, it would be what exactly treatment planning the cardiologists are thinking about, and what else the radiologist can add on, and other things. So there you have it, overall the overview. And if you have any questions, please write down and comment on it. I did not have a lot of time to have images, and I thought like um, putting up images takes more time in uh, just conveying the topic, and this is just meant for patients and to know that there are lot of options there radiologically speaking for heart diseases. So yeah, like a screening of heart diseases is actually a way that we can do right now, like which wasn't really something available 10 to 20 years ago, especially MRI, which has become so accessible nowadays, even in developing countries. And I feel MRI is really underused modality. Similarly, I feel nuclear medicine again is underused when it comes to cardiac diseases. And also because of the lifestyle choices, um, more young patients are landing up with the cardiac problems, and in them also monitoring and screening would um, make a huge difference. So this will also be a question for policymakers, that how they would like to incorporate MRIs into a routine practice, where because 2D echo is more or less go to um, modality when it comes to heart diseases. And I don't really oppose that. That's really quite a good modality. However, you cannot uh, play every match with the same bat, and sometimes you do require to bring big guns. And so that's what I meant uh, when it comes to cardiac MR. It can really give you answers about function, and sometimes even about prognosis, and especially about when there is a question whether it is a hibernating or really infarcted myocardium. And as I have touched upon, the niche topics like ion overload, those also the things which should, for which it should be utilized, which I don't see that frequently, even though now it's catching up. Uh, if there is any topic which I have missed, please let me know. If you have any questions, please free to comment. One more topic I did not touch upon is cardiac tumors because they are really rare, and in that MR plays awesome role because you will know enhancement pattern, you will know whether it's a clot or tumor, you will know whether how much extension it is, whether the mediastinum is involved or not, the resectability of that lesion, all those questions uh, would be answered with MR. So MR would be a really good standard where um, good modality when it comes to cardiac tumors and all. Thank you so much. Have a nice day.